Okay, so I'm Bruce Lambert from Northwestern University in the Department of Communication Studies and the Center for Communication and Health, and this is part 2 of my presentation on a patient-centered perspective on medication use, self-regulation versus adherence. So we have this problem. In part 1, I talked about how patients don't follow medical advice a lot of the time. Here I want to try to think about why that might be the case. So one of the big problems is that regimens, and by here I'm talking a lot about drug therapy regimens when we ask people to take medicines, but this is true of other kinds of regimens too. That the regimens which we give people to cure them, or at least in the case of chronic illness to treat them, often cause body failures as well as cure them. Remember from part 1, a body failure is a tremor, a limp, incontinence, fatigue, dizziness, etc. These ways that our bodies fail us when we get sick. So we get medicine or other regimens to take care of these body failures, but the treatment often causes body failures as well as treating them. And this is one reason why people might not take them. So here's another postcard from Post Secret. It says, this is a prescription package for citalopram, so it's antidepressant. It says, taking these didn't make me any less depressed, but they did make me shit myself in church. So this is a body failure caused by medication. The question is, how eager would one be to take this medicine if this was the consequence? Here's another one. I stole this postcard. My bipolar meds stole my art. So here's a critical example of what happens a lot of the time, is that the regimens which health professionals ask us to follow interfere in some critical way with a performance which is central to the maintenance of our identity. And if that happens, we're going to choose the identity-relevant performance instead of the treatment. So this person is taking medicines for bipolar disorder, and they're an artist, and they said, stole my art. This is a direct, the medicines are a barrier to this person being the person that they want to be. And my prediction is this person would stop taking these medicines for that reason. Sometimes medicines work, and they treat body failures. They don't just cause them. So here's an example of a postcard. Someone, I waited 43 years to get on an antidepressant. I love life so much now I use its name for my computer password. So sometimes medicines do exactly as we hope, and they treat the underlying body failure, and we are able to restore the integrity of the BBC chain because the medicine works. So I think, everyone who gets into the health professions in one way or another is motivated to try to relieve the suffering of people who are sick. And I think that the trajectory model makes an enormous contribution by giving us another perspective on what actually causes suffering in chronic illness. We often think of suffering in terms of physical pain, but I think there's a very narrow model of suffering in chronic illness, and I actually don't think physical pain is the primary form of suffering in physical illness. I think that suffering is a consequence of this chain of events. Our bodies fail us. So something goes wrong. I become dizzy, I become fatigued, I become incontinent, I lose my memory, I lose the ability to speak, something like that. And then because of this body failure, I experience a failed performance. That is, I can no longer do one of the things in the social world which I need to do to be myself. That's a failed performance. And when I fail at this performance, I experience the loss of self. I can't be myself because I can't do the things which are constitutive of my identity. I can't do those things which make me who I am. So my body fails, then my performances in the social world fail, and then I experience a loss of self. I'm not the person that I used to be, and then I suffer. So this is the chain reaction, which when we're thinking about chronically ill people, that we want to short circuit and stop, because this is eventually what leads to suffering. So key to this is this idea of identity-relevant performances. And identity-relevant performance is any performance, and by performance I mean behavior in the social world, that's central to the maintenance of our identity. So for each of us, I do this exercise when I teach this in a classroom, that I ask students to write down who they are, to list the top 3 identities in their lives. And they'll say, I'm a student, I'm a son, I'm a husband, something like that. And then I say, for each of those identities, what is the behavior or the performance which is most central to that identity? And no one has difficulty completing this task. For each of our identities, there are associated performances which help us maintain those identities. These I call identity-relevant performances. So, body failure only has biographical significance. It only matters to us and matters to our biography when it impedes an identity-relevant performance, when it gets in the way of us being the sort of person that we want to be. We're actually able to tolerate all sorts of different kinds of body failures as long as they don't get in the way of identity-relevant performances. There's lots of hidden body failures which we can handle. There's even visible body failures which we can handle. As long as they don't get in the way of our critical identity-relevant performances, we actually won't suffer very much. We might visibly look disabled or in some other way unusual or abnormal, but we won't be suffering unless the body failure interrupts our identity-relevant performances, and then we will suffer. So here's some more examples from Post-Secret. My depression skews my data. I feel like a bad field biologist. So this is a classic example of illness, rather than the treatment, interfering with an identity-relevant performance, collecting accurate data in the field as a biologist. So here's this example of a condition called focal dystonia, which I think most vividly illustrates the connection between identity and body failure. So focal dystonia is a condition where specific muscles, you either lose control of them or they begin to spasm. It most frequently, at least most notoriously, affects musicians and other artists, but it can also affect athletes and other people who tend to use parts of their body in a repeated way. I know of a weatherman who got focal dystonia of his vocal cords, and golfers sometimes get focal dystonia and they can't putt anymore. And pitchers sometimes catchers can't throw the ball back to first base. But most often, if you look up focal dystonia on Wikipedia, you'll see a list of all the famous musicians who have gotten this condition and can no longer play their instruments. So what's interesting about focal dystonia as an example is that it seems to target precisely that behavior which is most central to our identity. So in some ways, focal dystonia is one of the cruelest conditions because precisely that behavior, which is central to our identity, is targeted by this particular illness. There's another kind of dystonia or another kind of condition called vocal fold bowing, which has to do when there's a little gap between your vocal cords which can make your voice raspy and give you voice fatigue and so on and so forth. So here's a picture of vocal cords where you can see this bowing. So this happens to be, that's me. So I have this condition, vocal fold bowing, which accounts for the sort of raspy voice that I have sometimes. And here I am, I look like that deer in the headlights. Just like that picture before. I didn't feel that scared when they were doing that test, but they're about to put this tube down my nose, and I don't to look at my vocal cords. I don't think I'm very excited about the tube going down my nose. But I have this condition, vocal fold bowing, and it hits me right in the identity because I talk for a living. So as a teacher, I have to be able to speak. And not only that, but I'm a professor of communication. So communicating is central to my identity, and yet I have this condition which affects my ability to speak. I ignored it for a very long time until it finally interfered with my identity-relevant performances, that is, lecturing. I became so hoarse and my throat was so sore after lecturing that I finally went and got it taken care of, and thankfully through a variety of exercises and speech therapy, I was able to take care of it. So, loss of self is the fundamental form of suffering in chronic illness. It's fundamentally what causes us to be unhappy when we're sick. It isn't the physical pain. It's not as though physical pain is enjoyable or something like that. But it's physical pain that interferes with our ability to be the person that we want to be and to live out life according to our hopes and dreams and our biography. That's what causes us to suffer. If people are able to keep doing what's important to them and live out their hopes and dreams, they can endure a tremendous amount of physical pain and not experience this existential suffering, this depression and feelings of meaninglessness and hopelessness and suicidality that people do experience when they have loss of self. So that's why we call loss of self the fundamental form of suffering in chronic illness. So here's some more postcards from Post-Secret to illustrate some of these points. I'm so scared I will never again be the person I was before I got sick. This is just a very literal statement of the fear of loss of self. This person, and I was never surprised to see these things on Post-Secret because I knew that the trajectory model came from interviews with chronically sick people. So the trajectory model wasn't a theory made up by Anselm Strauss and Juliet Corbin. They were just translating what their interview subjects had told them. So again, chronically ill people feel this all the time. They feel this tremendous fear that they're not going to be the person they were before they got sick. And they were tremendously emotionally attached to our identities. So when we feel them slipping away, it's a very acute and terrible form of suffering. So she says, I'm scared I'll never be the person I was before I got sick. I miss her. This is this palpable sense of loss. Here's another one that talks about restoration of the sense of self. Smoking weed has helped me remember who I was before I developed the mental disorder. Again, it echoes this theme of loss of self and what people will do. They'll improvise any solution that they can to restore their sense of themselves, their pre-illness sense of themselves. This is, I think I have breast cancer, but I won't tell anyone because I don't want to be the sick girl. So all of this gets this idea of stigma or spoiled identity, loss of self that comes with illness and sometimes too often with treatment. So I hate that cancer is a fight and infertility is a loss. All of this has to do with the meanings of illness. So not only do illnesses have meaning, but medications have meaning, especially in relation to identity and biography. So here's more slides from or postcards from Post Secret. This one says, "I'm scared the antidepressants will change who I am and no one will like me anymore." So I've talked about how body failure can lead to failed performances and lead to loss of self. And sometimes medications and other treatments can cause the body failure. But sometimes being on medicines, especially powerful psychoactive medicines, can seem to change our personality. I've learned this especially from David Karp, who's a sociologist who studies patients who are depressed and what is it like to be on medication. He has a great book called "Is It Me or the Meds?" Where teenagers are asking themselves these changes that they feel in themselves. Is it the illness? Is it their own changes? Is it the medication? And so on. So this person who wrote this postcard is afraid that their personality is going to change in some way because of the medication. People won't like them anymore. It's again and again this connection between medication, identity, and illness, which I think accounts for lack of adherence, why people don't follow instructions all the time. Here's another one. "This pill could change my whole life for the better. I won't let it because I'm scared and part of me thinks I don't deserve it." So all of this is complex connection between the decision to take medicine, beliefs about our identity, about our self-image, about our value and worthiness, and so on. So it isn't simply a matter of forgetting to take the medicine, where if we only gave people better pill boxes, they would take their medicine. No matter how good a pill box you give this person, it's not going to affect this decision. This decision is embedded in questions about meaning and identity and biography and so on. Here's another one. "You know what scares the hell out of me? The fact that my sanity is subject to the mercy of words and symbols scribbled on a prescription pad." So one of the main thematic ideas in the meaning of medication is this idea of dependence, that central to most of our identities, at least in the United States, is the idea of independence and autonomy. And when we get sick, we're often dependent on medications, even medications that don't make us physically dependent in the sense of addiction. We have to take them all the time in order to maintain our health. And so we feel, at the very least, psychologically and emotionally dependent on them. And this person is echoing the resistance that they feel. And so one common reason why people don't follow instructions is they're trying to reassert their autonomy over the sort of tyranny of these regimens, which they feel dependent on. Here's another example. "I'm terrified that I'll come out of the closet when I'm anesthetized." So here's this unusual form of body failure. They're afraid to get anesthesia at the dentist. This is a note from their dentist. They're afraid when they're anesthetized at the dentist, they're going to come out and suffer this identity disruption. It's an unusual example of identity disruption being affected by the side effects of a medication, or in this case, the intended effects of a medication. Here's this great book by David Karp, "Is It Me or My Meds?" which anyone who's interested in these ideas, I highly recommend it. It goes into great depth in the connection between medication and identity in the context of adolescents who are suffering with depression and on taking antidepressant medication. David Karp, along with Charmaz and Corbin and Strauss, has really shaped the way I think about these issues. So the question of to take or not to take a medication is much more complicated than is ordinarily believed. And I like to use the analogy that the question to take or not to take the medication is a to be or not to be question. To be or not to be a certain sort of person. So it's a deep existential question people have to ask themselves. What sort of person do I want to be? Do I want to be the sort of person who takes this sort of medication, who carries this stigmatized label of a particular illness, or who suffers these particular side effects of the medication, who's dependent on medication? Or do I want to be a different sort of person? So people, when they weigh the decision to take or not to take a medicine, are weighing the identity consequences of the decision and biographical consequences of the decision. They're not just thinking about, will I be able to remember to take it twice a day, or will it make me have dry mouth or something like that? So in summary, medicines both cause and cure body failures. The critical linkage here between body failure and suffering begins with body failure, leads to failed performances. The failed performances cause loss of self because we can't do the things which make us the person that we are, and that loss of self leads us to suffer. Only some performances are relevant to our identity. There are some things we can do without. If I could never wash dishes again, I could probably survive. Although, washing dishes is part of my identity as a father, but I could do without it, and I wouldn't suffer if I couldn't do it anymore. But other performances, in my case, the ability to speak, are central to our identity. So if I couldn't speak, I would suffer tremendously, a loss of self. That medications have meaning, that this meaning is weighed heavily in our decisions about whether to take it, especially the meaning of the medication in relation to our identity and our biography. And often the decision to take a medicine or not to take it is a decision to be or not to be a certain sort of person. So with that, I end part 2.